Hi, everyone. I'm Jared Gardner, and I'm a dermatopathologist and bone and soft tissue pathologist. And today we are doing a discussion of myxoid and mucinous skin lesions. And I have here my awesome dermatology and pathology residents currently from UAMS, as well as my soon-to-be new dermatology and pathology residents and also fellows at Geisinger Medical Center, where I'll be starting work in June. So we're going to talk about some myxoid lesions today and see what we can do with that. So I'm using slides that are uploaded on Path Presenter, and at the end I'll share a link to this presentation with you. And also for those of you watching on YouTube, I'll put a link to this down in the video description so you can actually go see all the digital slides for yourself. So for this first lesion, you can see we've got a nice ellipse or a wedge of skin that's been taken out all the way down to the subcutis. And let me move this around here so that it's right side up. Even from low power, you can see that the dermis is very blue. And that's because there is deposition of mucin there. Now let's talk about mucin and another word, myxoid, for a second. Both of those terms I tend to use interchangeably. The reason is that if you talk to pathologists, people that are pathology trained, when they see blue gooey stuff like this, what they're going to say is, this is myxoid. If you ask a dermatologist, what this stuff is, they're going to say, oh, that's mucin. So mucin is a term that dermatology trained people tend to use when they're talking about hyaluronic acid, and myxoid is a term that pathologists tend to use. So it means basically the same thing, hyaluronic acid or other glycosaminoglycans, ground substance, right, that are secreted by fibroblasts. In this case, you can tell that the entire dermis basically has been replaced by mucin, okay? The normal collagen, so the papillary dermis is still there, right? Papillary dermis is made of very fine, delicate collagen, right? And you can still see that it's intact. But the reticular dermis, the big chunky bundles of collagen, there's a few of them left, but most of them have been pushed out of the way completely by deposit of mucin, okay? So you can see that that's what's going on here. And it's just a whole sea of it, filling the whole dermis pretty much all the way down. There's a little bit of dermis left here hanging on for dear life. But basically, the whole dermis is wiped out. There's very little in the way of cellularity, maybe some scattered inflammatory cells in here, a few fibroblasts, but really not many cells there, just a bunch of mucin. So even without any clinical history, what is this probably, what diagnosis would you give to this? You're welcome to type in your responses. No takers. It's okay. There's a chat box you guys can pull up and type in if you want, but yeah, this is myxedema, pretibial myxedema or localized myxedema, okay? So yes, this was actually from the anterior lower leg, the shin, and that is by far the most common site for this. It can sometimes occur in other places. Let's see, I think I've got a little PowerPoint slide here. Let's see if it worked. Yeah, good. So localized or pretibial myxedema, the classic clinical is that you get these waxy plaques that have kind of a poterange, orange peel appearance. And they're usually on the anterior shins, tends to be bilateral, and in patients with Graves' disease, hyperthyroidism. So patients don't have to necessarily be hyperthyroid at the time that the disease presents. They can be euthyroid or even hypothyroid. Sometimes they can have non-classic presentation. I've seen a few times where they presented as nodules rather than plaques. And they clinically, at least in a couple of those cases, were clinically mistaken for paniculitis, for erythema nodosum, because they were kind of erythematous, tender nodules and didn't look classic. There also rarely can be elephantiasis-like diffuse swelling of the whole lower extremity that has an elephantiasis appearance. And then rarely, usually it's a late manifestation of Graves' disease. The patients already usually have known Graves, exophthalmos, and then they develop pretibial myxedema. But there are rare times where it can be the presenting sign. And I've actually seen one case like that, that our diagnosis of pretibial myxedema led them to do testing, and the patient had Graves' disease that was previously undiagnosed. So that was kind of cool to see that happen, but that's pretty rare. The pathology findings, like we said, are pretty basic. Diffuse blue mucin replacing the dermal collagen. There's no fibrosis. There's no significant increase in dermal fibroblasts, so there shouldn't be a significant spindle cell component. And sometimes you can see basal layer hyperpigmentation of the epidermis overlying it. I think, if I recall, I think this case actually had a little bit. Yeah, so the epidermis, the redi were a little bit elongated, and there was quite a bit of pigment here. This patient actually was a Caucasian, had a light skin. So that's a lot more pigment than you would expect normally in the epidermis of a lighter skin patient. Okay, let's go to the next case. So here, you know, where do you suppose we are on the body? I mean, even at like 0.1x magnification, I still am not at the subcutis, right? Yeah, this has got to be the back of the trunk somewhere, right? It's like 5 miles thick dermis, okay? The cut's a little funny on the scan here, but the epidermis looks relatively normal. The dermis has got a little bit of solar elastosis, so they're probably an adult. Let me rephrase that. They are an adult. And the reticular dermis is filled with big, thick collagen bundles, as is usually the case in skin from the trunk. But in this case, the bundles really do get quite large down here, right? We talk about some entities as having larger or swollen reticular dermal collagen bundles, but that's kind of like one of those things you can hallucinate. Anytime I put a piece of back skin down, if I want it to be something with swollen, large collagen bundles, I'll say, oh yeah, look, those collagen bundles are a little bit big, right? They're kind of enlarged and swollen. And I see someone already noticed it. What's in between these big fat collagen bundles? Mucin. Pretty subtle. This case actually, even though I say subtle, this is about as dramatic and awesome a case of Scleredema as you're ever going to see. Usually it's like what you see is this. You'll see basically back skin with a little bit of blue mucin in between a few of the reticular dermal collagen bundles. It's usually very subtle and not dramatic at all. So basically, the clue to Scleredema is it looks almost like normal trunk skin, and you got to go down and hunt for mucin. And this one, though, is glorious, right? There's lots of mucin in between each of these collagen bundles. It's very nice. A little scattering of inflammatory cells. People don't seem to talk about that very much, but I have noticed that a few times that they can have a little bit of inflammation, but it's very sparse and minimal. Again, from low power, until you notice that blue, you'd say this is just a big piece of back or trunk skin. Okay, so that is Scleredema. And here's the little summary slide about that. Scleredema is these hard, shiny, indurated plaque. Usually the posterior neck, upper back region is the most common site. And people describe it as if you try to pinch it, you can't like get a good pinch on it. You can't get the skin to wrinkle. It doesn't pit when you push in on it. And we don't see this biopsied very often, but from talking at least to my current dermatology residents, many of them have said, oh yeah, we see it on a regular basis in clinic. It's recognized what it is clinically, so it's not biopsied that often. Okay, so there are a couple of forms. The two general big groups that it breaks down into is this acute form that arises more often in kids, usually soon after upper respiratory infection or other infection. Sometimes it can happen after other acute illnesses. And then also in adults, there's a kind of a more chronic form in adults, usually with diabetes, and more common, I think, in men who are obese and have diabetes. So that's the kind. I feel like I don't think I've ever seen one of the kid forms, again, because people are going to recognize it and not biopsy it. And one of the residents pointed out that there are rare times that can be associated with malignancy. So like many things in dermatology, right, there's always these rare exceptions of, you know, oh, sometimes it's associated with other strange things, but these are kind of the classic general things we think of. And the pathology, like I just showed, thick dermal collagen bundles with usually very subtle blue mucin in between. And again, no fibrosis, no increase in dermal spindle cells. Now, if you've already picked up the theme, you know the answer before I've even shown you, because you know that there's a trio of things that sound alike, and I've shown you 2 of them. So anyone want to take a stab at what this might be? Good. You guys are awesome. Yeah, this is Scleromyxedema or lichen myxedematosus. And this is much more rare than the other 2 entities. I've only seen actually a couple cases in training and 8 years of practice combined. It's quite uncommon. And what it looks like, it has mucin deposition in the reticular dermis, but with the addition of increased collagen, new collagen deposition, so fibrosis, and also an increased density of dermal spindle cells, dermal fibroblasts. So you can see there's still blue mucin in here, but definitely this is not the way that the reticular dermal collagen normally looks. There's a lot of increased small fibers in here in addition to the bigger ones, and there are more dermal fibroblasts than there should be in this area normally. So it's an increased density compared to normal, all right? And it's a kind of a thin zone here involving the superficial to mid dermis that you can see it in this case. And this is an example from the public library on Path Presenter. If you guys, I think you all probably know, but pathpresenter.net is this great site that's got thousands of slides on there. So I host a lot of my slides on there and use them for conferences, but there's tons and tons of stuff on there already that's public and free, and you can just search for any diagnosis and look at the slide. So let's look at the chart on this. So basically, this is rare. It's also quite complicated. There's been a lot of different nomenclature changes and subcategorization changes over the years. So the very basic summary, again, with many exceptions to all of this, is that there's kind of a localized form and a generalized form. And then there's this in-between form that doesn't quite fit. The localized form, there's actually several different subtypes, but most of those present with waxy, several millimeter waxy papules. That can be on the hands, the wrist, or other sites, depending on which subtype it is. And because they have these papular appearance, a lot of times the names like papular mucinosis get applied to this papular localized form of Scleromyxedema. And then there is the more problematic generalized form, which is what we usually, when we say Scleromyxedema, usually it's referring to this generalized form. And they do have waxy papules also, but they begin to coalesce and stick together and make these firm, hard plaques. And there's a variety of problems, that systemic problems, that generalized Scleromyxedema can be associated with. But one of the main ones that we always think of is that it has a paraproteinemia, a monoclonal gammopathy. And I think the majority of cases have this, and it's usually IgG lambda. Again, there are some exceptions to that, but that's one of the most prominent finding is going to be an IgG lambda monoclonal gammopathy. What we see microscopically is, like I just showed you, there's going to be mucin with the addition of fibroblasts and collagen deposition. And it can vary supposedly from early lesions to late lesions. All of the cases I've seen, I think, have been later lesions and have been more spindled and collagenous and not had very much mucin. But the early lesions, mucin is supposedly predominates. So in the McKee book, they've got a nice example of one that has a lot of mucin and just has a slight increase in spindle cells. It's certainly not nearly as much diffused mucin as you'd see like in a pretibial myxedema, and there are more spindle cells, but it's not quite as spindled and cellular as what I was just showing you. But the ones that I've seen have been spindled to the point that I actually start thinking about a spindle cell neoplasm. I feel like they often remind me of dermatofibroma, but with a little touch of mucin. And I'll show you why in a minute. I'll show you some more spindled examples. And a real important point to drive home here, dermatofibromas have so many different morphologic patterns and variations, but mucinous or myxoid is not one of those. It's weird because almost all spindle cell tumors seem to have a myxoid variant, but not dermatofibromas. Like I see dermatofibromas all the time, both as a regular derm path and also because I specialize in soft tissue tumors. And I don't think I've ever seen a good example of DF with myxoid change. And another colleague had mentioned that to me at a meeting that who sees a lot of soft tissue, that they've not seen that either. So I think if there is such a thing as a myxoid dermatofibroma, it's vanishingly rare. And I think if you think something's dermatofibroma and then you see myxoid change, you just got to back right up and go find a different diagnosis for that. And then the other thing I'll point out, even though it's quite rare now, is nephrogenic systemic fibrosis, which is this sclerosing skin disease that's really problematic that happens in patients that have been exposed to gadolinium contrast for MRI and then also have renal problems. And now that we recognize this happens, they don't give gadolinium contrast agent to people that are at risk anymore. So it's vanishingly rare. I think I've never seen a real case in practice, or maybe I've seen one. I can't remember now if it was a real case, or I saw it like in a teaching session. I can't recall. But in any case, it's really, really rare now. But to me, the NSF, nephrogenic systemic fibrosis, and scleromyxedema look identical. I don't know how to tell them apart by looking at them without the history. And I think even the McKee book says that basically they can look totally identical. So you have to find someone more experienced than me to be able to tell them apart. And yeah, the other name for nephrogenic systemic fibrosis, thank you to one of the residents who brought this up, nephrogenic fibrosing dermopathy. Thank you, Hugh, for bringing that up. So that's the other name for this. Okay. Now here are a couple of other examples. I thought it'd be good to show a few examples of this because it's so rare. So let's see some. So look at that. This is Scleromyxedema also. But look at how spindled it looks and how fibrotic. Like I wouldn't look at that and think, oh, this is a mucin deposition disease. Like where's the mucin, right? I mean, I guess there's a little bit of bluish gray color there, but it's certainly not very pronounced. So that's been my experience, is that these lesions don't really look very myxoid most of the time in the rare cases that I've seen. So and you can see how this can get confused with dermatofibroma. Look, it's got collagen trapping. It's kind of bland spindle cells. There's a little wrapping and trapping around collagen. And again, clinically, it looks like a papule. So unless you know that it is multiple papules, right? And I've actually seen, and yes, my fellow Dr. Caitlin Campbell said that this also could look like granuloma annulare. And I think that brings up a good point. Dermatofibromas, particularly kind of the subtle atrophic ones, can look a lot like the interstitial areas of granuloma annulare, because both of those diseases have spindle cells that start to wrap and trap around collagen bundles. So I think it's totally legitimate to consider interstitial GA, dermatofibroma, I guess scleromyxedema. I never thought of putting that on the list. And also hypopigmented blue nevus. All of those can have that similar look of bland spindle cells wrapping and trapping around pre-existing reticulodermal collagen bundles. So this is another example. And I actually did see a case once. I never got the follow-up on it, but it was sent in to me as a spindle cell tumor, and it was from a papule like on the arm or somewhere. And then they had another one on the other arm, and they both look kind of like dermatofibroma, but with a little bit of myxoid change. And I said, you know what? I wonder if this is scleromyxedema. And I got a copy of the clinic notes, and they said the patient also had some facial papules that have been bothering them. And so I said, well, I think it's pretty concerning, and the patient needs more workup. And no one ever got back to me with follow-up after I verified that case. But it was a good lesson of here's someone that actually sent it in thinking about a spindle cell lesion, and it ended up being, I believe it probably will end up being scleromyxedema. So I wish I would have gotten the follow-up, but that's the consulting world, is that sometimes you just don't ever find out what happens in the end, which is not satisfying, but we just do the best we can. All right, and then here's one more example. And again, kind of the superficial, the mid-dermis seems to be ideally involved. Again, it's spindle cells and collagen. You can see this kind of wispy pink collagen in addition to the darker pink, thicker collagen bundles. The cellularity is way too high for the dermis at this level normally. And again, the mucin is just kind of, you have to kind of hallucinate that there's actually mucin there. There's a vague blueness to the dermis, but really is pretty subtle. So it doesn't really look that myxoid to me. Okay. Now, let's transition from that. Oh, I forgot there's one more thing to cover first. Make sure I've got this visualized here for the video. Okay, so I made this little chart. I spent a little time photoshopping today, and this is a kind of a side-by-side comparison. Pretibial myxedema, blue. Sea of blue mucin replacing the dermal collagen. Scleredema basically looks like normal trunk skin, but with a little bit of subtle mucin in between. And then scleromyxedema basically looks like a fibroblastic or collagenous lesion that has a touch of blue mucin mingled into it. So I hope that helps you sort them out. I think these diseases are unnecessarily complicated because the names sound so similar. So they are almost like name-alikes more than look-alikes. And I think that's a problem in much of dermatology and dermatopathology. There's an awful lot of lichen this and pityriasis that, and I think that's very confusing to beginners until they learn about all of the different diseases that are possible that have these overlapping, similar sounding names, but quite different features.